So with regard to Marco's clinical case, and I know that he's a very keen endovascular interventionologist and very keen doing all these fancy interventions. I'm very happy that Lucia pointed out what we should do first, supervised exercise training, and I'm also very very keen to do endovascular procedures in patients with lead. But with regard to these patients, you always have to know and look at this kind of patients and look what you should do. So we face so many patients with lead now, and especially with intermittent claudication, we cannot put them on the Cath Lab table right away. So we have the strategy to put them on a waiting list, and this waiting list is 3 months. And what we see from our clinical practice is that a certain percentage of these patients does not need any endovascular or intervention in the follow-up because they do more and more exercise. We also use the Nordic ball. We show this kind of patient when they visit us the first time, and that helps, and we spare endovascular revascularization in not all and not the main percentage of patients, but in some. So this is something you always have to have in mind, not go for endovascular first, especially in a patient who might not be that compliant. So anyway, my task is to talk about revascularization, endovascular revascularization. I would just give you insight in when to indicate this kind of revascularization procedures, how to prepare a patient, technical principles, follow-up, imaging, the access path, and how to puncture, material science, closure of puncture site, and then some insight in balloon angiography, stents, and alternative fancy tools. I will not go into direct comparison with, for example, inner claudicant, with Bob disease, with a Piper's, because in my opinion, and also as we have lined out in our guidelines, this is not appropriate. So only symptomatic patients should undergo revascularization. And in 2018, especially for patients with intermittent claudication, endovascular first is the main approach. And the symptoms qualifying patients for treatments are patients with Rutherford classification 3 to 6 or Fontaine 2P to 4. This means lifestyle limiting claudication after no improvement after 3 months of exercise training, and patients with CLTI, critical lymphatic ischemia, which means rest pain, non-healing ulcers on the foot, gangrene, or necrosis. This is just the classification we use. You can either use Rutherford or Fontaine. More common is Rutherford, and I think it's also better showing what kind of stage or grading or category the patients might have and what kind of clinical symptoms these patients might have. So the pitfalls, especially in patients with claudication, is the walking through phenomenon. Typical claudication, which is not causing patients to stop walking, as typical claudication symptoms are getting better or are stopping when keep on going. And this is also the case in patients with peripheral neuropathy. So patients with diabetic or chronic renal failure do not sense the claudication. So these are the two main pitfalls if we look at claudicants. And one thing which helps in finding this kind of patients or identifying this kind of patients is the treadmill test. And I think, or the 6-minute walk test, there are different tests out there you can use. If you have a treadmill in your institution, this is the easiest way to apply it, or then there are other tests like the 6-minute walking test, which is a standardized test and which also helps to identify this kind of patients. Preparing the patient. So, I mean, Marco was showing us a female which might not be that compliant with all these comorbidities and not stopping smoking. But this is something we face a lot in patients with lead with peripheral arterial disease. So therefore, if you apply this kind of procedures. You have to explain the purpose, the course, and all side effects. And you have to take time to do this. And you also have to ensure that the patient and his relatives have enough time to ask questions. And we should not persuade patients going into these procedures. And you should always illustrate your plans and your procedure, and then you should get a valid signature of this patient. So do not talk the patient into this procedure. Be really honest, and ask also the family or the friends or whoever is with the patient how they have an insight in this procedure, because you can end up with some kind of complications, and these complications might be severe. So the risk assessment ahead of revascularization, there should also be a risk assessment, which are laboratory parameters like creatinine levels, coagulation parameters, platelet count, hemoglobin levels, and also you should look for thyroid disorders, because if patients have hyperthyroidism, such kind of a patient should not undergo a revascularization, especially in the claudication immediately. And then there are some issues with co-medication and also with medical conditions. Mainly, if patients are on diabetes, there is some discussions. You should stop some kind of anti-diabetic drugs if patients are under oral anticoagulation, or if they have already suffered contrast agent-induced nephropathy. This is also something you have to take into consideration, and also known allergic reactions in the past. This is not uncommon. So vital signs should be monitored during the intervention. Why? Because especially patients with lead have a very high cardiovascular risk. And due to the antegrade approach, which is really the best one, especially in patients with lower extremity below the knee disease, retroperitoneal puncture bleeding can occur, and therefore patients need to be monitored also after the procedure. And I would suggest a monitoring of these patients of at least 24 hours, and vagovasal reactions can occur. So if you go into the Cath Lab, you have a certain workstation. This is the workstation for the interventionist. You have the patient's positions. The most preferred one is the antegrade approach from the ipsilateral groin, as you can see here, because you have better pushability and trackability of the devices. But you have also alternatives to the patient's conditions, for example, from the contralateral groin, crossover, transbrachial, and also popliteal retrograde, as you can see here. These approaches get more and more important because we face more and more patients with obesity, and we have to look for other alternative approaches. And there is also, especially from the Italian guys, the retrograde cruel approach, especially in patients with below the knee disease and hard to revascularize arteries below the knee. In the Cath Lab, you see, this is not different from a Cath Lab from a cardiology unit. You have all these usual things you have to prepare. You have to prepare yourself, you have to prepare your assistant, and you have to have a lot of different devices in the Cath Lab, and I advise that you really know what kind of devices you have with you in the Cath Lab, and that you are trained with this kind of devices if you go through this kind of procedures. So there is no evidence-based for both procedural regimes so far. There's a common agreement that patients should have a bed rest between 6 to 12 hours with regard to the different closure devices. You should monitor the hemodynamic values, the pulse rate and the blood pressure. You should check the hemoglobin and creatinine levels at least 24 hours afterwards, and you should do the ultrasound the day afterward. So the most important thing is the comparison before and after. So do an ABI before and after, do an ultrasound before and after, and see if your procedure have been successful. Especially in a claudicant, with this lesion, Marco has shown us, you can have some acute reocclusion just the day after, and the patient is not walking because he had the bed rest and is not feeling any symptoms because he said, okay, I didn't walking, goes home and comes back with the same symptoms. And for example, if this patient had an acute reocclusion, which is just not worsening his symptoms in such a complex lesion, I would not go for another revascularization. So I think this follow-up is very important. The ball position for the indication of revascularization, in my mind, has duplex ultrasound. In the second row, it's MRR or CT angiography, because, for example, with MRR, you have the advantage. It's more costly. You cannot do it by yourself, therefore second row, but you have the advantage to see the whole vessel in one image, and we will see this tomorrow during the hands-on workshop, what are the advantages of MRR or CT angiography. CTR, the CT angiography, wins the race over MRR with regard to stent placement, because if you have stents already placed somewhere, you will see by MRR a total occlusion, so you cannot judge that, and by calcification. So one thing, this is a very nice image of a CTR, of a CT angiography, we see this calcification, and this is not a very nice patient you want to treat with an endovascular procedure. You can do everything, but this is not recommended, in my opinion, if the patient just has mild or not lifestyle-limiting claudication. And not qualifying at time right now is just angiography, because you only should do an angiography when you do an endovascular procedure at the same time. As we face the more and more patients with impaired renal function, we do more and more CO2 angiography. And the improvements really have made over the last years. This is very complicated concerning all the equipment you need, but you also get a very nice picture, and the advantage is that you do not harm the renal function with this kind of approach. How to puncture? Mainly common femoral artery, antegrade, as you can see here. Also retrograde, as you can see here. This is mainly for crossover in obese patients where you need to go to the other side. Can also be tricky because the pelvic arteries are sometimes very kinking or show a kinking, and therefore it's not easy to go from the contralateral approach, but with more and more obese patients, this is one approach how to do it. Then we can go transpopliteal or in the distal SFA, especially if we have chronic occlusions and we are not able to go through from antegrade. It's much more easy to go through from retrograde. Maybe Jean-Baptiste might not be very keen of this new different approaches because endovascular specialists are doing more and more fancy procedures and spare bypasses. This, if such a patient has not been successful with an easy to approach from antegrade, and you think of all these procedures, I think, and I would advise to look for an interdisciplinary session or an interdisciplinary approach, so that this patient should be discussed also with the vascular surgeon if this patient should not undergo maybe for a bypass surgery, even if it's only a claudicant, and even if this patient might not have that long lesion in the SFA. So if the procedure is not easy, I would really recommend, and this should be done more and more, this interdisciplinary approach, how to treat such a patient. You can also, you see here, these different ways of transpopliteal distal SFA retrograde approach and how this works with then the so-called rendezvous techniques. There are so many new techniques out there, but they only should work, and I only would recommend that for very experienced physicians. Then there is the so-called transpedal approach, also highlighted especially by the Italian interventionists, especially as they face a lot of patients with diabetes and therefore critical chronic critical threatening lymphedema. And you can also do a plantar approach. So you see all these fancy approaches, but if you have to go to this way, then you should really have this patient discussed before in an interdisciplinary setting. The transbrachial approach is getting more and more important because once again we face more and more obese patients and we are not able to puncture the groin. So what do you need about your own toolkit? You have a lot of different stents, sheets, guide wires, catheters. Please select one toolkit within your Cath Lab and try to work with this, and then just be very careful. If you new devices, you should really know how to handle them and undergo a training. There are a lot of things out there, different kind of stents, so you really, if you want to use this, you need to know what kind of stents, drug-coated balloons, how they work, how you should apply them. So this is some advice, not just take something and use it within the patient. You really should undergo a training. There are fancy tools like, once again, so-called puncture devices where you can do a re-entry. This is only for very experienced hands. The closure of the puncture device, there are different ways to do it. Just make a compression with some things you can use in add-on. You can also do it like this. You can also use a closure device, but once again, it depends on how the patient looks like, if he's obese, if he's moving afterwards, or if for example, the puncture site is very calcified, then you cannot use a puncture device. Now we got a little bit into detail. How should we do an endovascular approach? Mainly by balloon angioplasty. In 1974, the first balloon angioplasty of a popliteal stenosis was performed at the University Hospital of Zurich by Andreas Grünzing, and this was the main approach for over 40 years. BOBA is just mechanical, so we did this for 40 years. And we have now to treat the underlying disease, so we also use drug on our balloons. We use drug-coated balloons more and more because the atherosclerotic tissue is the cancer of the vessels, as we call it in the endovascular space right now, and the immunosuppressive therapy is mandatory to prevent reobstruction in add-on to best medical treatment and exercise training. We have a lot of drug-coated balloons out there. The principle is that we blew up the balloon and that the drug is adherent to the vessel wall and gets into the vessel wall, and there in the vessel wall stays for a different time span, a minimum of 30, but also a maximum of 90 days, and prevents the reobstruction and the restenosis at the place where we did the angioplasty. There is just one trial data I want to show you, and this is the drug-coated balloons compared to BOBA. In the meantime, we have level 1 evidence that in the SFA we should use a drug-coated balloon. So in the kind of patient Marco has treated, I would have used a drug-coated balloon right away. There are different drug-coated balloons out there. These are the 3 ones which are FDA approved, and for these drug-coated balloons we also have long-term data up to 4 years showing us that these balloons are working quite well and showing us long-term patency and freedom from clinical driven TLR, so no symptoms over the time course. Stenting. We only should stent in the different vessel areas if there is a mechanical issue, flow limiting dissection, reocclusion after the angioplasty, or more than 50% restenosis after angioplasty. So primary stenting should not be done. Why? Because we have a problem difficult to treat the instant restenosis, which occurs in some kind of stents up to 40%, and we also have the stent fractures, and we tend, because we treat more and more complex lesions, to cause and to create a so-called full metal jacket. 2018, we have a lot of alternatives and fancy tools. We have lithoplasty to correct the calcium, which is also getting now into the coronary field. We have spot stents, the so-called DEX, so just, to apply this kind of tiny 6 millimeter long stents where it is needed. We have injection system where we can, the bullfrog system, where we can inject different anti-proliferative drugs into the vessel wall. And we also have the so-called lymph flow system, which is a new one, which is transforming veins to arteries by bypass grafts. But these are fancy tools and not for regular use, and many of them will still need to evaluate with regard to their long-term outcome data. So, revascularization in lead. I hope you all are joining the group. The working group of peripheral arterial disease. You see, we are coping with a lot of topics, and I guess this training here shows you that we are really dealing with every aspect of lower extremity arterial disease, and maybe next year or within the next years we can also show you that we are treating with a lot of other things like veins and pulmonary, whatever. So. The peripheral vascular is, I guess, in good hands within this working group, and I hope you're joining the group. Thank you very much.
Thank you very much, Marianne, for this comprehensive presentation of the revascularization from basic to more complicated, to give also a really nice view of all that can be done, and that was very nice. Some comments, some questions?
Immunosuppressive treatment, what did you mean?
We use paclitaxel, which is just applied on these balloons. No. It's just it's just like you have in the coronary field the drug-eluting stents. Drug-eluting stents are not working. Not in that extent as in the coronary field. So we go with revascularization. We did for 40 years. We did it mechanically, and I guess this is not the final approach. So because in the peripheral vessels we have this 1 meter long leg on the one and on the other side, and we have large distances we want to treat. And in addition to what we can do with medical therapy, with exercise therapy, just to treat the underlying atherosclerotic disease, we do not only do the mechanical part alone, which is not sufficient, and then just fix it with a stent. We apply something like paclitaxel in a very, very tiny amount on the balloon into the vessel wall to prevent restenosis and to get a better long-term result. We have now data up to 4 years, which are promising, and I think this is a very good basic concept. It's not difficult. It's just ballooning with immunosuppressive drug in addition. It's something a little bit different from the coronary.
Thank you for your presentation, dear Professor. I have a question, a clinical question. I want to ask you, I understood you use Fontaine classification of PAD. But I have a question. How we must estimate this stage of PAD when patient has COPD, when patient has low fraction ejection, and when has arthrosis and another problem? Thank you.
In the ESC guidelines 2017, we have the so-called masked lead with regard to all these kind of patients who have chronic obstructive pulmonary disease, who have neuropathy, whatever, orthopedic problems, who do not feel this kind of claudication, which is lifestyle limiting. But they can use some kind of questionnaires. As I have pointed out, you can use this 6-minute walking test or whatever. And if you do it really in a staged procedure, you also can diagnose this kind of patients and get an insight if the walking distance is a problem for this kind of patient, or if not. But Rutherford, I mean, I would go to Rutherford because it's more precise in my opinion, and I'm not so much in favor of the Fontaine classification, to be honest.
Any further remark or questions? Yes?
In hemodialysis patients who have a non-normal ankle brachial index, when sent to a surgeon.
You mean patients, when I will send a patient to the surgeon?
Before critical ischemia.
Okay. I mean, in 2018, it's really endovascular first, especially in claudicants. If the patient has a lifestyle-limiting claudication, we are not successful with revascularization. Before we go for fancy procedures, we would discuss with the vascular surgeon if this patient would be a candidate for bypass. Usually, it's not a candidate for bypass. A lot of these patients do not have a too high surgical risk. This kind of patients might have no veins, more often as you would think. They do not have any veins. Then we go with, when we discuss it with the patient, then we go for maybe a more aggressive approach with regard to the endovascular procedure. In critical emphysemic patients, in acutely emphysemic patients, when we see that maybe our outcome might not be because it's very complex disease, we discuss it. This is the luck we have at our institution, interdisciplinary, on a really daily basis, how we should treat this kind of patients. And I think this should be, in an interdisciplinary team, this should be the best approach how they address this kind of patients. In critical emphysemic, threatening emphysemic, more surgical than endovascular. In claudicants, more endovascular than surgical.